I've been doing this for more than 10 years, and the learning curve just keeps, going up. And I by no means feel like that I'm at the end of that learning curve. Like I really learn every day.
Welcome to the Dr. J.J. Thomas Podcast.
Hey everybody, welcome to the Dr. J.J. Thomas Podcast. I'm J.J. Thomas, and today I have my very dear friend and special guest, Dr. Johannes Roedl. Welcome.
Thank you, JJ. Yeah. Thanks for having me.
I'm so honored to have you here. I was telling Doc before we started how, one of the reasons I wanted to have you on is because I've found through my relationships with doctors like you that I've been able to help more people. We've been able to help more people collectively, collaboratively together than I think either one of us could maybe on our own. So today, one of the reasons I was excited to have Dr. Roedl on is not only to share his gifts and talents and skills as a musculoskeletal specialist and an interventional radiologist, but also just his experiences with collaborating with physical therapists like me, and I'm hoping it can benefit you PTs out there as well. Side note, if you're a patient or a regular person and watching, you'll learn a lot too, because he does some really cool things that maybe would help you. So anyway, we'll get started.
Thank you, JJ. Thanks for having me.
Yeah. So I thought I'd share with the group a little bit first about your background. If you could, out of your words, kind of tell me, first of all, in your own words, how you do what you do. And then also a little bit about your background and what led you into musculoskeletal radiology.
Yeah, of course. So I grew up in Germany, and I did medical school there, and then trained in Boston for 10 years, and then came to Philadelphia. And my specialty is really, it's a little bit of a strange niche. I always say it's strange because it's not as common, because I come from the radiology, from the imaging side. So I did radiology, interventional radiology, and then specialized really in the orthopedic system. So what I do is I do orthopedic procedures, but I don't do surgeries. So I'm really, and that's what really is along with the lines that you said earlier. I'm in between what JJ does with physical therapy and surgery, and that kind of entire space in between is what I cover. So a lot of it is injections of biologics, PRP, stem cells, and that background, having that background in radiology and interventional radiology, which are really the experts in guiding needles in the right space, that helps me to get those biologics and PRP treatments in the correct tendon, muscle, or in the joint space. And I think this is kind of the somewhat different approach to a lot of other folks who work in that area, that I do have that interventional radiology background. Also from an imaging perspective, I'm trained in reading MRIs. So when patients have MRIs or need MRIs, I can directly relate to that and help in the interpretation as well. And then ultrasound is the main tool that I use for diagnostic purposes, to make the right diagnosis, and then also I use ultrasound to guide the needles in the right spot.
Yeah, that's one of the things I've loved about working with you is, well, first of all, back to what you said about the skill of being able to look at the imaging. And I think, you that rolled off your tongue so easily, and because I know you do that every day, but as an outsider watching you do your work, I think that's so valuable, as you said, for patients who are trying to figure out their next step. Like, is their next step to go see the orthopedic surgeon? Is their next step to just continue on the conservative physical therapy track with us? And I think what I've seen through my work with you is that you have developed such a Rolodex, if you will, or a history of, this case looked like this, we treated it this way, and it responded well, or it didn't respond well, that you're really able to help patients make those decisions. And that's been really fun to be a part of watching you.
No, I agree. And I think with ultrasound specifically, because you are someone who comes from the movement part of medicine, so everything is in motion, and that I'm a big fan of that as well. The problem that I have had with MRI in training is that it's static. So patients are flat, lying in the scanner, and you don't see like joints or tendons in motion. With the ultrasound, machine. And this is really the same ultrasound that we have been using for decades, in pregnant women to image babies. We use that now for the last really 10 years. It has been taking off in the orthopedic system, the musculoskeletal system, and we can image and see tendons and joints in motion. So when I have a patient, I always do dynamic imaging. So I look at the extensor tendons, if I have a pitcher, a baseball player, the UCL, the ulnar collateral ligament in motion, and we can stress that joint and see how that ligament acts. And you can do that with MRI or X-ray. So that's the huge advantage of having that ultrasound from a diagnostic perspective.
That is. I had the pleasure of getting to watch Dr. Roedl do his thing one day, and it was definitely one of the highlights of my career. And that was one of the things I was most impressed upon. Like, as physical therapists, we train our physical therapists, and we are trained ourselves to do special tests and to see, if it's gapping, or to feel if it's gapping. But that's such a subjective thing, sometimes really hard. We're listening to pain, but you can literally see inside it while you're doing those dynamic testing. It's really cool.
Yeah.
The other thing I found really surprisingly interesting when I was there with you was we had a case where I believe it was a football lacrosse. Anyway, he had a pretty large hematoma, and I just watched you drain it. I was like, you guys, you could literally just see this like suck out of his it was in the adductor. And I'm like watching it like I was like a kid in a candy shop. I was like, that's amazing. I mean, some of the stuff you can do for just getting, obviously inflammation has its purpose, and there's potentially a need for some of that inflammation to facilitate healing, but also when an athlete needs to get back, it can sit there and, like I describe it to patients, like marsh water, it can inhibit the healing too. So I found it really cool that you could see that real live as well.
No, exactly. I mean, this is really going back to using ultrasound then for procedures. Like it's very difficult to do any of those procedures blind. And we always thought that even the easiest injection, like a knee joint injection, we always thought that experienced orthopedists would have a close to 100% rate of success of getting in the joint. But there have been studies actually that did show it's way below that. So, it averages out to about 80%, so, which is not bad. But if you have 10 patients, 2 of them do not get the ideal injection in the right spot, as a patient, you just don't want to be in that, in those
80% sounds great unless you're in the 20%.
Exactly.
So
that's the advantage really with ultrasound, that it's basically guaranteed, if you have the experience to do procedures, that you get in the right spot. And this is with something like a hematoma aspiration, you really have to find that pocket in that hematoma, which you can only see on the ultrasound, to really be able to drain it. And the same we always talk about injections and biologics, like what is the best? Is it PRP? Is it stem cells? But it all starts really with the image guidance. Like it doesn't, there's no value if you have the best product, the best PRP that is out there, but if you don't get the PRP like in the exact spot where it has to go, it's completely useless. So that's why I think that it can be overstated, like how important like ultrasound really has become for orthopedics in general.
Yeah, I'm glad you said that, because that's something we try to stress with our participants in our courses in general, like especially with dry needling. It's like you can teach someone to needle, but if you're not needling the right spot, it's the same exact thing. Like a lot of people are needling just the painful areas, but they're missing the movement. You said yourself, like we're movement we consider ourselves like movement diagnosers. And if you're not needling the right spot, it's the same thing. It's not going to help. Yeah. So that's awesome. I wish I send so many of my patients to you, and exactly, not only because of that, but because I know, actually, I even watched Dr. Roedl when I was there. He's one of the first docs that I've seen in the office really do a retest. Like he you took the time to actually do an assessment instead of just sort of going right to the imaging. Like you also used all of those clinical tools and matched up what you saw movement-wise with what you were seeing on the imaging.
No, it is really a fascinating field. And at the same time, what I said so far, everything sounds easy, but it's also very, very humbling. I mean, I've been doing this for more than 10 years, and the learning curve just keeps, going up. And I by no means feel like that I'm at the end of that learning curve. Like I really learn every day, and, the potential is still so much greater. There's so many more advancements in technology we will have the next few years, and I'm really just proud that I'm able to be part of the group in that field. So
Yeah.
I'm really excited about the future. But it is very much something that you can't take for granted. I mean, it's really something that takes practice, experience, and then as a physician, we always have to stay humble and continue to educate yourself, learn, talk to colleagues, go to meetings, talk to other experts in the field like you. And I think that's something that special connection we have had is that makes me so much better in my job, like knowing what you can do with your group here. And that's important, I think, for any specialty to keep reaching out, and not only in your own specialty, because after a while you kind of you lose the big picture.
Yeah.
So I'm always looking to really stay in close contact with orthopedic surgeons,
Yes.
physical therapists like you, trainers, athletic trainers when it comes to the sports teams. That's really where I learn most these days. So it's huge.
I think, and we all learn from each other. Like you said, I do think when it's about the patients, that's the other reason I think you and I connected right away, is like our true mission is really to help each patient. And so, as you said, if we're really going to help patients, the best we can do is learn about other professions that are treating the same type of patients with the same type of problems, so that when our patients need their services, we can refer them appropriately.
Yeah.
And that is like so many times now that I have this relationship, it's so much easier for me when I have a patient where I'm like, oh, I just don't know. I'm like, go see Roedl. It's so much easier.
Yeah.
So I'm thankful for that. And I know you're always learning. I know you also are doing a research project, right? Currently.
Yeah, we always.
Talk about that?
I'm still very close involved in research with the university, and one of the main things I'm working on is really figuring out what the ideal biologic is. Like, is it PRP? Is it stem cells, or specifically bone marrow aspirate injections that I mainly perform? And then I have several projects that are ongoing with the professional sports teams, where ultrasound is really also becoming extremely valuable, especially during the games. I do ultrasounds there diagnostically, where you can then decide if someone has, let's say, a hamstring injury. Is it a minor injury during a game where it's really very subtle and the player functionally can still do what he has to do during the game? We can send them back out. If it's something more serious, a more moderate grade strain, then we completely pull them out of the game. So
awesome.
This is something that we weren't able to do really in the past. So these are examples of the professional level, where ultrasound, just as much as for our weekend warriors and regular patients, has made a huge impact. So that's exciting. So I do a lot of research in that area as well.
Yeah, in terms of the rapid ultrasound testing to see where we go from there.
Exactly,
That's great.
And basically in game, during the sports games.
That's great.
It will really be in orthopedics. I think it already is, but it is kind of aside from the physical exam, almost like the next best thing, or the partner of the physical exam, I would say,
Yes.
Where ultrasound will just completely take over the diagnostics. Because you can't have an MRI scanner. Yeah, there are some sports stadiums that have them, but it's really not during the game, because it takes, as you know, it takes 20, 30 minutes to get an MRI. The ultrasound, I can, within 30 seconds often, I can make a diagnosis.
So cool.
So that's just priceless, especially in the sports world.
Yeah. And you mentioned, I know we just had you come out recently for a talk on the benefits of PRP versus stem cells. And I would love if we talked that a little bit. And also, I will say, when you and I first started working together, I believe I even called you because I was like, okay, doc, people are talking to me about, let's actually go here for a second. People are talking to me about stem cells. And I came to you asking about the difference between bone marrow aspiration stem cell versus, umbilical cord stem cells. And can we get into that a little bit? So more honestly, my intention here is for patients to understand, because I do think patients hear stem cells and they sort of think, they don't really know where they come from.
Yeah.
And I think there are even therapists out there who aren't sure exactly where they're coming from. And what's your experience with that?
Yeah, no, that's a great question, because there's so much out there in the public, and a lot of misinformation, and patients are, I think, being promised a magic wand, with stem cells, but it's really not that easy.
Yeah.
I mean, the short answer, and the probably more frustrating answer, is that it really depends on the patient.
Sure.
So that's why, for me, the most important thing is to see the patient, examine the patient, do the ultrasound, review any other imaging that has been done, MRIs, etc. And then also look at the patient's goals and, is the patient a professional athlete, a weekend warrior, or someone who doesn't do sports at all?
Yeah.
And at the end, any of those treatments, might be right for that specific patient. But I always feel that when it comes to stem cells and PRP, that PRP has been so successful, really, and we have significant data that I usually, in most patients, start with PRP. Also because the access and getting PRP, which stands for platelet-rich plasma, so it's really for you guys who are not familiar. It's done by a simple blood draw, so it's very easy to get. So the patient gets a blood draw, the blood goes in a centrifuge, and what we isolate from the blood are the platelets, because the platelets are the cells that release growth factors, and your body naturally uses platelets to heal injuries. So if you have a cut in your arm, the body basically sends platelets there to heal that cut, and we are basically trying to replicate the body's response by doing a blood draw and getting those platelets and injecting those platelets into the injury. Let's say you have a hamstring tendon tear or tennis elbow with a common extensor tendon. So we basically use your own body for healing. And the reason why I do like PRP is because it's very safe to get those cells, and the outcome has been generally very, very good. It depends on the injury and the severity, obviously, but overall patients do very well. If patients don't respond well to PRP, then I usually go to the more advanced biologics, which mainly in my practice is the bone marrow.
Yeah.
So instead of a blood draw, we draw bone marrow, which is actually, it looks similar to blood.
Yeah.
It's a little thicker, and it has stem cells.
So cool.
And those stem cells they're a little more potent than platelets, so they release different growth factors, and they also, at least in theory, we think that those cells can develop into like cartilage cells and cells of the muscle, myocytes, that can then really heal injuries even better. So that's overall like my approach, is to start with the least invasive and
the more studied.
And the more studied,
Yeah.
and really the one that has proven results, at least in most practices. So that's why, in general, going back to the first statement, it depends on the patient. But if you ask, like in general, I would say like PRP first, and then bone marrow.
Can we talk a little bit more? I remember when you came and talked with our crew about some of the benefits and some of the ways you do your procedures. You talked about the different percentages, like how I didn't realize until you came and gave us that talk that different docs will do different percentage of, I think, platelet versus, right? So
exactly. So there's one big group of PRP. One is called leukocyte rich and one leukocyte poor.
Yes.
So the platelets are high in both groups, but it's the leukocytes that make the difference. And leukocytes are the white blood cells, and those are cells that cause inflammation. So really, depending on the condition, in some conditions, in some injuries, you really want inflammation. And that's mainly conditions that are chronic. So if you have someone with chronic patellar tendinosis that has been going on for months or even years, you really want to stress and stimulate.
Yes.
And the white blood cells are perfect for that, because you inject those with the platelets, and that causes inflammation, and the body really wakes up and tries to heal that tendon.
Boom.
And it's
like a
inflammatory.
cue, right? Like
exactly, like you tell
time
your
to work.
body,
Yeah.
wake up, there's something wrong.
Yeah.
It gets inflamed, and then the body will respond and will try to heal. And you can, and on the PRP systems, in most of them, you can basically pick, it's a simple button in a preset.
So cool.
If you want leukocyte rich, so you want the leukocytes in your product, in your PRP, or if you don't want them.
That's great.
There are some injuries where you don't want really the white blood cells, you don't want inflammation. That is usually true for joints, because it's not a good idea to inflame a joint too much.
Yeah.
Right? You can inflame a tendon, but inside a joint that usually has not good effects overall. So the inflammation should stay down. Like if you have a patient with a cartilage defect, you really don't want to inflame that cartilage more. You want this to get the good cells, the platelets, but then kind of let it rest.
You don't want it to see it as a threat. That's how we would talk about it probably, right? Like you don't want the body to see it as a threat more.
Exactly.
Right?
So in joints, usually we stay with leukocyte poor, so not many leukocytes. And also, if someone has an acute injury, for example, if we have a muscle injury, a muscle strain on Monday morning after the football game on Sunday, there's already enough inflammation there. Your body, if something happened yesterday, there's enough inflammation. You don't want to add on to that inflammation.
Great.
So we stay away from the white blood cells, the leukocyte-rich PRP, so we do the leukocyte poor there.
Yeah.
So that's really the big, the two big groups are
awesome.
leukocyte-rich and leukocyte-poor PRP.
When we were talking about the chronic cases, I was thinking, I know some docs, I don't know how you feel about this, but some docs, for a while, it seemed like the standard was doing like a tenotomy with the PRP injections. Do you still do that as standard if you're doing like a leukocyte-rich? Or not always? Again, I'm sure it depends on the patient, but what are your thoughts on that?
Yeah, no, that's a great question. So I still often do it because the great thing about the tenotomy is that you, for example, going back to the extensor tendon at the elbow with the tennis elbow, that there's often so much scar tissue that has built up, with the tendinosis, that it's good to go in first and loosen up, release that scar tissue. It's almost like a debridement. And that also creates space for the PRP. Sometimes the tendon is so tight and so scarred that when you try to inject PRP, there's no space to go anywhere. And with the tenotomy, with that needling first, you really break up the tissue, release some of that bad tissue, and then you have space for the PRP. So in the vast majority of patients, I do the tenotomy, the needling before.
That's great.
Hamstring also is a good example. Adductor origin, that's usually pretty aggressive tenotomy.
That's great. That's all really helpful information. And what is your frequency? Like if you see someone for a PRP injection, when do you like to follow up with them usually?
So I give every patient my email also, and there's some form of follow-up, mostly over the phone, about 2 weeks. I would like to hear from them, just to see how they are, giving any other instructions regarding rehab PT, if they're ready to go back and ramp it up in PT. So that the 2-week follow-up is the first one. And then it really totally depends on the injury. But I usually like staying in close contact with patients because, especially with the PRP, there is often like a series of 3 injections. So I bring them back. And that also depends on the injury, but a common protocol is like 1 injection and another one 6 weeks after the first, and then another 4 to 6 weeks after the second one, the third one. So that's like a common protocol, but it also depends really on the injury.
And so I know when I heard you say that when you came to lecture with us, that made sense to me because of tissue healing time. Therapists like 4 to 6 weeks for soft tissue healing time. So if he's doing PRP in a soft tissue area, that makes complete sense to me. Another question that I remember picking your brain about, because it varied. Like when I first started hearing about PRP procedures being done, way before I even met you, many docs at the time were recommending like strict rest for like a long period of time, like 6 to 8 weeks. And it was, as a therapist, I was like, oh my God, I need to keep them moving. How am I going to do this? So, and I know things have changed, I think, on the research front with that. And so if you could maybe speak to that a little bit.
No, that has really completely changed. When I also started like 10 years ago, we had patients, for PRP around the ankle tendons in the boot for like 6 to 8 weeks.
Yeah.
And then in arm slings for rotator cuff PRP and other things, and that completely changed. So I never really immobilize anymore. And patients, it's really very simple. Like I tell patients that there's nothing you can do after the PRP to undo it. So you can stay almost as active as you would like, but I know that the first week,
they're going to be sore because they probably had a tenotomy and
Exactly, they can't do much. And the reason why I say that there are no limitations at the beginning is that I want patients to not be scared at all of moving. And all they do at the beginning is really just, getting around like daily activities. It depends on the PRP where you give it, but usually patients do have soreness, especially the first 2 to 3 days. And then it's really getting back into PT pretty much right away. And there's some like a short ramp up, but it's really not like it used to be in the past,
Yeah.
where we are having patients rest like 6 to 8 weeks.
So thankful for that.
So that has really completely changed.
And because I work with you so much now, I just wasn't sure if that was a you thing or a trend thing. So I'm glad to hear it sounds like it's a trend in general with most docs, that they're getting rid of the long immobilization period after it.
Totally. I mean,
Yeah.
like when I said that anything is tolerated, I mean, if someone has let's say a grade 2 hamstring strain or like a high grade tear of the, let's say the patella tendon, I don't want patients to start running, like week 2. But I don't want patients, for example, with the patella tendon, we had them on crutches, so that has changed.
Yes.
We have them walk right away, as tolerated.
Because I think also what we know now too is that basically the PRP process is stimulating a healing process. But if you're not using that area, then the brain isn't gonna capture it as much, because if you're not using it, then it's not going to integrate it, right? Yeah. So I think, like, from our side of things, I think what I encourage therapists to do in our office is, like, let's say it's a grade 2 hamstring strain, like, we would still treat it the way we're going to treat it, by honoring the inflammatory process and honoring the muscle healing process in the sense, like, maybe we'll do muscle activation exercises, but we'll start with isometrics, so we're not putting too much stress on the contractile mechanism itself.
Exactly.
And just letting that good juice just sit there and do its thing.
Yeah.
But also integrating it neurologically and vascularly, et cetera. So,
exactly. Yeah, that's where everything is moving that direction. I couldn't agree more.
Yeah. What else do you see? So I want to pick your brain on this, and I hope you feel free to speak freely. But a lot of therapists are now starting to get into, like, getting ultrasounds themselves. And I know you and I talked about it briefly, and I would be lying if I didn't say there were times I was tempted. Like, we treat a lot of jiu-jitsu athletes, and arm bars, like elbow, they're so common. And sometimes I'm like, I wish I could just look at this real quick. But I also know it would take, I don't know that my accuracy would be so great anyway. It would take a long time, whereas you already have it. So I was just curious what your thoughts are on that, on therapists who are considering.
No, I think it's awesome. I mean, I totally encourage that. I mean, I'm excited when I see like therapists getting into that, or athletic trainers with the sports teams, because it would be sad if you would lose out on that technology. And like, everyone can learn it. You guys also have the huge advantage that the anatomy, because that's always number one. Yeah. Is like, you already know, like, where tendons attach, which tendon is where. So you have a huge advantage. I think that it takes a little bit of time, though. Like, I think it's easy to get, like, overly confident at the beginning, but on the other hand, you will also realize that
there's so much to learn.
At the beginning, when you look at any structure in the ultrasound, and you really have to look at hundreds of patients to know, like, what is normal.
I mean,
I feel that. Normal. So I think that's
just knowing, being humble with it at least, right? At first, and knowing your limits.
Yeah, and as I said earlier, I'm, like, still humbled every day by everything I do. And I think with ultrasound, especially at the beginning, it is a lot. I mean, it's not like one of the, for example, what I always say is, like, learning CAT scan, X-ray, and MRI is so much easier, because it's a static image. Yeah. And you can, there are books you can look up or read in anatomy pictures where everything looks the same as on that MRI. But if you have an ultrasound, you are the one who is taking the picture. So first of all, you have to make sure that you image the right spot. And then everything is also not as pretty. Like, it's prettier to look. Everyone can see an X-ray. Okay, that's the humerus, that's the femur. You can see the bones. Yeah. On ultrasound, it's not like that. The picture is pretty abstract. Yeah. It's all like gray and white pixels. So I think that my bottom line is, like, I would definitely learn it. Like, I encourage everyone to get into it, because I think it's the future, and it's fascinating, and everyone will love it. Once you get good at it, it's the best thing. It's great for patients, but it's not easy.
No,
it's not something that you can pick up over. Yeah,
so don't expect to buy this unit and then all of a sudden be diagnosing things. Right.
Exactly. It takes. I mean, it takes years. Yeah. To get really good at it.
Yeah. So what So I guess with that, I would love to be able to help that kind of along those same lines. I'd love to be able to help therapists, as I told you before the show started. I would love to be able to help therapists and other clinicians embrace this type of relationship that you and I have with our patients. And so I would love to hear from your perspective what you look for in a physical therapist that you'd like to collaborate, so that maybe they could mimic some of that and have those good working relationships for the sake of our patients.
No, I think in general in medicine, I think number one is always communication. Like if I think a physical therapist who is brave enough to reach out to other physicians, I think is key. Like if I only get the physical therapy, you guys have always a report. I'm not sure how it is with at least if you're insurance based, you get the report that
Totally.
That for me is no offense, but it's not nearly as good as having a direct conversation. So I think, and I know that time-wise that's not always possible, but I think if you really want to embrace that relationship, and I think it benefits the patient obviously at the end, like you would have to pick up the phone and try to talk to the physician, because that's really number one for me is communication. And then someone who is also like open to maybe doing things like a little different or outside the box, who is open to, especially if you have complicated patients, to be open to like new things. Because I think the problem in medicine we also have, sometimes you get into your ways that you've been doing for years or even decades, and you just don't want to get out of this.
Yeah.
But I think there are patients where you have to, otherwise we are lost. And you have to, be open to, if we as physicians have ideas that you could try differently, or the other way around, if you feel like, hey, there's something not quite right with this patient, like, did you look at that, maybe see him again or her and look at that part, of the injury. I think we're missing something here. So I think thinking outside the box, within the realms of like obviously being doing the right thing and being
not being crazy about it. Yeah, exactly.
I think that's important. So those two things, communication and having the willingness to think outside the box, are for me the most important.
I'm glad to hear you say that, because I know you're very deliberate with the way you treat, in terms of you honor the research, but I think a lot of clinicians in my world sometimes honor the research so much that they forget to look outside the box. Like they forget to ask. We don't get answers, in my opinion, unless we ask questions. And I think sometimes therapists want so badly to honor the research that they forget that maybe the research is 10 years old by now, and like they have to look at the patient and still ask questions.
Yeah.
So that makes me so happy to hear that. And the communication thing, I'm glad you said that, because now I've been a PT for 24 years now, and having these conversations with docs is very easy, because I've established, I feel confident in my conversations with docs. And so, but I remember, if you're a new therapist listening, I remember like those first phone calls calling doctors. And I will say, if you are a new therapist, it's worth taking the time to organize your thoughts before you call them, because if they're willing to get on the phone with you and they're as busy or busier than we are, I 100% promise you, then you want to make sure you're valuing their time. So my advice to you guys, based on what Dr. Roedl says, is like, spend 10 minutes before you call them back and get your thoughts organized on what they need to know, so that you're honoring their time, so that you're not rambling on and trying to figure out what your point is. When you call them, you have a mission, and you need to tell them exactly what they need to hear for their patient, and that's going to make your relationship with them a whole lot better.
Yeah, no, I agree. And I think you would be surprised how much it's really appreciated by physicians too, because I think for us also the other way around is the same. Like we feel like, should we try to call someone, maybe because you guys are just as busy, is it really, do they remember the patient? Is it complicated? Are they not in the office? But it doesn't hurt to
reach out,
to try either way, and I think I've never had a conversation with a physical therapist or really any other healthcare professional who's involved with a patient where I've hang up the phone and I was like, that was really useless. There's always something
Yes.
that we get out of it, and even if it's ending nowhere, it's still like, okay, at least we know that's off the table, or so I think it never hurts, and usually it's the right thing to do.
I'm glad to hear you. I'm glad you said that, because I think therapists are sometimes intimidated to call docs, so it's really good to hear. And they think that note is a way of honoring their time, but I agree with you. I always felt that way. I felt like the note was a little bit impersonal and not really giving the juice of what they needed to hear for those patients.
Yeah.
So that's great advice. Well, thank you. This has been so awesome. Thank you so much for sharing your knowledge and taking the time to just sit with us and kind of explore the realm of both what you do for therapists and patients who don't really know all the worlds of a musculoskeletal radiologist. And I know I always learn something every time I'm with you, so I'm sure they've learned a ton. So thank you so much.
Thank you. Thanks, JJ, for everything you do, and thank you to everyone who's listening. We really appreciate all the hard work you put in every day.
So if you guys, if you're in the local region, check out Dr. Johannes Roedl. He's very local, and you can find him easily by a Google search, or you can reach out to me, DM me or whatever, and I'll get you in touch with him. But he's very useful in the Philadelphia region. And if you're not in the Philadelphia region, I encourage you to go out and find somebody almost just like him. There's nobody just like him, but if you can find somebody almost just like him, then you're going to be in good shape for you and your patients and your business. So go forth and be awesome. Thanks. Take care.
Thank you, guys.